Okay, I am trying a different way to record this video. Hopefully it works because this will be my fourth recording today because Studio on Canvas doesn't want to work. So hopefully I can record it on my computer and just email it to you, and hopefully it works because I'm over Studio right now. Um, so I have none of the supplies I would need to actually teach this class, so we're going to use a lot of imagination when I give my presentation. We'll pretend that the bed is actually a patient bed, that the room is the patient room, um, that my dog is our CPR mannequin, and that my scrub top is the patient gown. But we're just going to make it work. So for this final project, I had throughout the course been developing education for an entire new graduate nurse um, introductory course that would take place over a couple of weeks. And then doing this actual final project, I did it over a 1 day topic over CPR and AED. And so for this video would be just the CPR portion because the class that I have, kind of envisioned in my head and kind of had planned for was 8 to 5. So to make it smaller and into a more manageable chunk, I'm just going to do the CPR portion. We're going to use our imagination and we're going to have fun. So um, I'm just going to get started. I'll pretend I'm in the patient room with all of my new graduate nurses. I'll have my rolling whiteboard. So, okay. All right. Hello, everybody. Today is our CPR course. Today's going to be different than any CPR class you've ever taken before. Today's focus is not on the knowledge about CPR, the amount of compressions, how to do compressions. Today is going to be more about teaching you how to do in-hospital CPR because there's things that you need to know about doing CPR in a hospital that are a little bit different than what you're taught in a CPR course. For example, in a CPR course, your mannequin is on the ground. They don't have any clothes on. They don't have any family members in the room. You're just working on your skills of CPR. So today, I just want to get your mind starting to think about different scenarios you may encounter in the hospital and how you can do CPR effectively in patient rooms because this is where you're going to do CPR. But first, let's go over the basics just as a refresher. I want you guys to tell me all of the things you think about when it comes to CPR. So I'll start. First thing that comes to mind when we do CPR is a 30 to 2 compression to breath ratio, right? And that's with a two-person approach. So that's what I remember from my CPR class. What do you guys remember from your CPR class? Okay, so you will compress the chest 1/2 to 3/4 the depth of a patient's chest. So when you do CPR, you're pushing their chest in half the distance that their chest is, or 3/4, in order to get full benefit of that compression. It needs to go that depth. What else? What else do you remember from your CPR class? Make sure the seat is safe. So this one, I'm going to put a little asterisk by it because, like I stated earlier, what you learn in your CPR class isn't always going to apply when it comes into the hospital. And this one is kind of an example of that. Our hospital rooms are safe. We don't have downed power lines. A tornado didn't just go through, God forbid. So we anticipate that the room is safe and when we're walking in. Now, if there's a puddle of water on the floor, yes, please don't slip and fall and hurt yourself because then you're not able to help the patient. But that's not something that we really emphasize or look for in the hospital. What else? What else can you guys think of? Okay, so the nipple line. When we do compressions, the right area to do compressions is on your right in between your nipple line for adults. And the reason why is because if you do compressions too low, the bottom part of your sternum, called the xiphoid process, can actually break off and long and kill your patient. And if you do compressions too high above the nipple line, then you're not giving effective compressions because you're not compressing the heart and making it fill with blood. You're compressing the aorta and actually preventing blood from leaving the heart to get to the rest of the body, which is the whole purpose of CPR. Anything else that you guys can think of? Okay, so somebody mentioned, I take it that you have worked in the hospital and seen this done. This 30 to 2 ratio of compressions to breath actually changes when there's an advanced airway in place. And what do I mean by advanced airway? An advanced airway is when a patient is intubated. So they have a breathing tube in. And when a patient has a breathing tube in, you are going to do continuous CPR. You're not stopping to give breaths because a person who is giving the breath, which in the hospital is going to be respiratory, they're going to give a breath every 6 seconds. So that's a big major change that we don't talk about in our CPR class. And it's something that you have to keep in mind when you're doing CPR, especially in the ICU on an intubated patient. You are just continuously doing CPR. Because they have an advanced airway in place, respiratory will deliver a breath every 6 seconds. And in our hospital, most of the time, respiratory is going to be there, being the person who's delivering the breaths. And we can deliver breaths until respiratory gets there, but once they get there, they take over that role. So the nurse who was doing the respiratory role can do something else, such as be a compressor or a runner or something like that. So those are some of the basics to keep in the back of your mind when we're talking about CPR in the hospital. But today I really want to focus on the differences that you might see in different scenarios that you need to think about while you're working in the hospital doing CPR. So I'm going to set these aside. We'll have these up so you can refer to them if you need them. So let's go over to our patient bed and our mannequin over here. Okay, so we're in the patient room. Every patient room has a code blue button. The code blue button is going to be above every single headboard. You have the code blue button, it is blue, it says code blue, so no matter what room you're in, no matter what floor you're on, you'll be able to identify and find the code blue button because it's the exact same in every single room. Along with the code blue button, all of our patient beds have a red pedal at the head of the bed and it says CPR. That CPR pedal will flatten the bed when you need to do CPR. So if a patient is like sitting up or the knees are bent or something, you can push down on this pedal on the patient bed and it will automatically flatten the bed. Okay? So here we have our CPR mannequin. Our mannequin has a gown on and we have our family member here. So when we are looking at this mannequin, what's something that you notice about the mannequin? I'm thinking about if I wanted to start CPR on this patient. They're really far away from me in this bed. They're on the opposite side of the bed. So if I were to try to do CPR, I'm going to be leaning and I'm going to be pushing. I'm not going to be able to get effective compressions. So what are my options? What can I do to make sure that I am in a proper position to do CPR? Yes, I could move the patient to the floor. That might take a lot of time. In the hospital, it is not uncommon to see a nurse get right on the bed with that patient and begin performing CPR. A lot of times, you're not going to have a stool right away that I could stand on in order to perform CPR better. So you'll see nurses get up on the bed. You might see nurses get up over the patient and straddle them, especially if we need to take this patient to cath lab because we suspect they had a heart attack and we're moving. You'll see if nurses straddle the patient and continue CPR on our way to the cath lab. So that's not uncommon. What are some other things about this patient other than them being really far away? They've got their gown on. Our gowns are made to rip off and be taken off quickly. So I'm going to take that gown off and expose the nipple line so I know that I'm placing my hands in the proper place. Anything else? Yeah, so this patient, theoretically, hypothetically, is kind of sitting up. So I can press that CPR pedal and it will flatten the bed for me, and then I can perform CPR. Because you don't want to walk into a patient room and they're sitting up at a 90-degree angle, they don't have a pulse, and they're sitting here trying to do compressions like this. Okay. So let's say this is my patient. I'm walking into the patient's room and I'm saying, hello, good morning, Mr. Jones. Mr. Jones, he's not responding to me. What's the first thing that I'm going to do? Check a pulse. Where do I check a pulse? You have two choices. You have your carotids, which is here, and your femorals, which is down here. Personally, I find it very, very difficult to feel femoral pulses without a Doppler. So I always go for the carotids, and it's just a lot easier. You're never going to feel both at one time because you can cut off the blood supply to the brain. So just one at a time, you'll feel the carotid pulse. How long do you check a pulse for? Right, so we check a pulse for a minimum of 5 seconds, but no longer than 10 seconds. So I'm going to sit here and feel a pulse. While I'm doing that, what are some other things that I'm looking for while I'm checking this patient's pulse? Right, so I'm checking to see if they're breathing. I'm checking to see if maybe there's something in their airway that's blocking their airway, making them unable to breathe. You're right. So all of those things. I'm checking pulse. I'm assessing the patient. I notice they're not breathing. They don't have a pulse. I'm going to hit that code blue button right there because we all know where it is now. I'm going to push the pedal, the CPR pedal for the bed to make it flat. And I'm going to start doing compressions, right? So as I start doing compressions and my team runs in with the crash cart and stuff, you'll notice when I do compressions on a patient bed, the entire bed compresses along with the patient. So your compressions are not effective. You need something hard underneath your patient in order to prevent them from sinking into the patient bed. So as you're doing compressions and your team is rolling in, you're going to use closed loop communication and be clear and concise about what you need from your team in this moment. So your priority right now is going to be, I need a backboard. So you're going to sit here and you're going to continue to do compressions. Your team is going to grab the backboard. The person is going to go to the opposite side of the bed and they're going to say, on the count of 3, let's put the backboard under the patient. And you'll say, I'm very tired. After that, I need to switch compressors. So you're doing compressions and you'll say, 1, 2, 3. You're going to help roll the patient, slide the backboard underneath the patient, and then someone else can take over or you can resume if you're feeling like you can still do effective compressions. Once you have that backboard under the patient, then we run the code like normal because now you have extra hands. You've got a recorder, you've got someone doing medication, someone running the AED. And we'll get into that more throughout the day. But right now, I just want to focus on CPR basics. There are going to be times in the hospital where there are more than one code going on at once. So you're using the crash cart in another room, and you don't have a backboard for this patient. Do you guys know of any other options that we could use for a backboard if the crash cart backboard is already being used in another room? The head of the bed. Every patient bed has a removable headboard that can be slid under a patient and be used for CPR. What happens if you walk into your patient room and they're sitting in a recliner and you determine that they're not breathing and they don't have a pulse and they need CPR? Yes, you could pull them to the ground. Some patients are going to be too heavy to do that, and you're going to need more than one person. So what you can do is you can hit that code blue button, and you can start prepping the patient. You can take their gown off. You can clear an area on the floor. You can push the bed out of the way so that you have a place floor where your team can effectively do CPR. I have done CPR on the floor many times because patients don't just lose their pulse in bed. There's one time a nurse and I were getting a patient to a commode and she slumped over. I think she had a massive stroke, to be honest, but she slumped over, she lost the pulse, she was a full code. And we couldn't at the time feel her pulse or anything because we were physically holding her up because she had slumped over. So the nurse was able to reach the rapid response button and people came in and we were able to pick her up and put her on the bed and then assess her and realize she didn't have a pulse, so we started CPR. So those are things to think about, that you cannot effectively do CPR on a commode or in a bathroom. You need to get a patient to a space where there's enough room for the entire team to get in. And whether that's on the floor or on the patient bed, either way, just make sure there's enough room for the team. Eventually, if we're doing CPR on the floor and we need to like place an airway or something, we'll eventually need to move the patient to the bed. But that's a call by the provider that they can make during that time if they feel like the benefit outweighs the risk. So anything else you can think about that we need to discuss when it comes to certain scenarios in the hospital? Anything that you've seen in the hospital, certain scenarios, questions you have? Yeah, so larger patients. Patients that are physically larger, they weigh more and they have a lot more body mass. It can sometimes be harder to determine if you're doing CPR effectively. So you just have to be self-aware and know that when you feel fatigued, that even if your 2 minutes of CPR is not up, that you ask for relief. Because that's not doing the patient any good if you feel fatigued and you're not able to compress as deeply as you need to. Because regardless of the depth of their chest, based on their weight or something like that, you still have to compress it to a certain point, and that's that 1/2 to 3/4 depth of their chest like we talked to before. And someone that weighs more, it takes a lot more muscle and a lot more effort to compress their chest that depth. Something else that I want to talk to you guys about is when you're doing CPR, you're going to break patient ribs. It's inevitable. It's how you know you're doing effective CPR. And when you're doing compressions, whether you're the first or the second one, you're going to feel ribs break. And the best way that I can describe it is if you took a carrot and you snapped it in half. That's the feeling. So keep that in the back of your mind if you start to do CPR, especially if you're the first or second person, because you're the person who's going to break the ribs. Don't hesitate. Don't stop. Don't freak out. It's normal. It happens in CPR, unfortunately. I remember the first time I did a code on this 85-year-old lady, and I was the first one to do CPR, and I felt it, and I freaked out because I didn't know what that was. And I kept going, and I thought to myself, that's what breaking a rib feels like. And that feeling has stuck with me forever. So just remember that wherever your patient is at, recliner, chair, make sure they're in the proper position and that you are in the proper position. Whether you need to physically get onto your knees onto the bed or straddle the patient or use the stool that comes with the crash cart so that you are getting the proper depth and that you're not just using your arms, you're using your full body, that your hands are placed where they should be, that the gown is off so you know where you're doing compressions. And you need that gown off anyway to start placing your AED pad. So I mentioned the family member here. In the hospital, you're typically not going to do CPR on a patient when it's just the patient in the room and there's no one else around. You're typically going to have family members, and those family members are going to be scared. They're going to be crying, sobbing, yelling, reaching for their family member. They're going to be trying to be all over your patient that you're trying to code here. So what you need to do as someone who recognizes this, and maybe everything else in the room is taken care of. Someone's doing CPR, someone is working the AED. Maybe your role is that you grab that family member and you take them aside and you say, "My name is Callie. I'm a nurse here in the hospital, and I'm so sorry that this is happening to your family member. Can you tell me your name and your relationship to the patient?" And let's say they say, "Oh, my name's Milo. I'm his brother." And you say, "Okay, Milo." You say, "Murphy doesn't have a pulse. We're doing CPR to get his heart back." You say, "Milo, I want to let you know that this may not be pretty, that this could be very hard for you to watch. If you would like, we can step out of the room so you don't have to endure that. Or if you want to stay in the room, that's fine. We just need to step to the side and I will stay with you through this process and explain everything to you. And you can ask me any questions you'd like." In this scenario, Milo wants to stay. So I would say, "Okay, we move to the side of the room because the providers need all of the space around the patient in order to do effective CPR." So we pull him aside and we say, "All right, Kara is providing compressions. She's the one on the bed. That's so that blood can keep circulating to his vital organs." And then maybe the provider orders one of epi. You explain to the patient that epinephrine is a medication that can be used to start the heart. Maybe they want to intubate the patient, so you walk them through what that's going to look like, that that's a breathing tube that would be inserted into their throat and he'd be hooked up to a ventilator to breathe for him. And those sorts of things. You really need to use compassion. Try not to use medical terms because a lot of times these family members are not medically aware of, things like intubation, ventilator. You have to use language that the everyday person could understand. If you're not good at talking to family members and being able to hold your composure while they sit there and sob, then that role is probably not for you. You'll learn as you go through codes and as you go through these scenarios what you're best at and where you can help your team the most. I personally am really good at family members. I can be very compassionate, I can be very calm, and I can be very reassuring, and I know that about myself. So if I come up into a code and I see a family member, that's typically the first thing that I jump in and do because I always put myself in their shoes if that was my family member. So I know that about myself, but I'm also very competent in all the other roles, but that's typically a role that gets overlooked in the hospital, especially because we don't learn about that in our CPR class. Do you guys have any other questions? Okay, perfect. We'll break for lunch.